So I'd like to introduce the speakers. We chose the speakers because they have expertise in different areas, which is wonderful. It's a wonderfully balanced panel for tonight. Our first speaker is, and you have this in front of you, so I don't want to just read it off to you, basically, but Ann came down from Sacramento. Ann Kuhns came down. She's the president and CEO of the California Children's Hospital Association, of which there are 8 California children's hospitals that she represents. And really what CCHA wants to do, as it says in your materials, promote well-being, really promote access to high-quality pediatric care, which is, again, as I've mentioned, a bias of mine, and long-term, helping to ensure long-term stability of freestanding children's hospitals, too. Previous to this, Ann has significant government experience that you can talk about and was very involved in the move from fee-for-service Medi-Cal into managed Medi-Cal when she was working with the state. And so Ann's seen both sides of it, I think I'd say, because, you know, that was a huge change to move from fee-for-service into managed Medi-Cal. So I'd like to invite Ann up to speak.
Thank you, Lisa. I'm going to spend a moment. I'm what you might call a technological Luddite, so it always takes me just a minute to get oriented. So I wanted to talk a little bit just about giving you kind of the 30,000-foot view of what's going on with the financing of pediatric healthcare in California and what it kind of means for providers. There is a lot of change. We're in the midst of a very rapidly changing healthcare landscape, both in terms of the financing and in terms of just the public policy around healthcare delivery. And I think about this to start. I was just looking for some data over the last week as I was putting my slides together, and I found this actually this little video on the California Department of Finance's webpage. And the California Department of Finance does population projections because they're the governor's arm that kind of does budget projections and things like that for programs. So they do help put together census data, but they also do projections. So what this little video shows, oh, now I've got to find my little, there we go, is it shows you the population growth from 1940 through estimates through 2060. So what you can kind of see as it goes up, it's like, there you see the baby boom kind of pushing through the system. And then what you see by the time we get to 2060 is a very significant growth in the number of people. I'll do that again. I guess it stopped here. It goes really fast. It starts to look like this big rectangle, and you have all these people now living, over 65. So the fastest growing segment of the population in California is 65 plus, and it's actually expected to grow from, I think it's 4 million people in 2010 to over 12 million people in 2060, which is a growth, I think, of 190% or something like that. Whereas the population under age 18 is expected to grow from 2010 to 2060 by about 14%. So you don't have a significant growth in the pediatric population, you have a significant growth in the aging population. And that growth in the more senior population is a big concern to policymakers. And I don't know if you guys are familiar with what Medicare is versus what Medicaid is. When I first started working in healthcare policy, people used to tell me Medicare ends with the letter E and it's for the elderly, and Medicaid ends in the letter D and it's for dependents. And just keep that, it's just a point of reference, the way to remember it. And then of course in California we call them Medicaid, Medi-Cal, which is confusing. But a lot of policymakers really focus, especially at the federal level, on what's going on with the Medicare program, because Medicare is completely federally financed. But at the state level, what is a big concern to state policymakers is the Medicaid program, or in California, the Medi-Cal program, because the state pays roughly 50% of every dollar for the state Medi-Cal program. And Medi-Cal covers mostly families and children, and then a population of disabled adults and children. So here we have 37 million people living in the state of California in 2010, and that's 12% of the U.S. population. So, but when we think about, what does that mean relative to Medi-Cal, which is the big state payer of healthcare, Medi-Cal actually covers a third of all Californians in the state, and I think Lisa had mentioned that earlier. And that population growth that we see sort of on the slide that I just showed you is partly responsible for what's going on with the Medi-Cal population. But the Medi-Cal population, seniors and persons with disabilities, and I grabbed this chart from the Legislative Analyst's Office, which is the financial advisors to the legislature. And this is a 10-year chart, both actuals and then projected through 2016-17. So you can see the seniors and persons with disabilities who are part of the Medi-Cal caseload. That caseload is growing about 2% a year. And then families and children, they tend to be sort of counter-cyclical relative to the economy. So you tend to get a little up and down. Generally, historically, you've gotten a little bit of up and down in that population. When the economy's bad, you get more people on Medi-Cal. And when the economy's good, you get fewer people on Medi-Cal. But that trend line you can't really see because of the scale here. But then what's happened is under the Affordable Care Act, the state had the option of expanding what we call the optional eligibility category. So you take all adults. It used to be Medi-Cal was more of a program for families with children, and the population that was pretty much excluded from this was childless adults. And so the state had the option to under the Affordable Care Act, to cover that population in the state, which the state of California has a relatively generous Medi-Cal program relative in terms of benefits and how many people are covered. The state obviously opted to do that optional expansion, and that's really caused an explosion in terms of the overall caseload growth for Medi-Cal. So while California accounts for 12% of the overall population, we actually account for 17% of the country's Medicaid enrollees. And so it's the fastest, the Medi-Cal budget is actually the fastest growing part of the state budget, which makes it's kind of like a very large container ship, it's huge. And even little things, even if we think it's very hard to move that big ship around, and the state is very reluctant to consider, big changes in the way it deals with providers, because the state's always very concerned about, well, if we increase anything a little bit, it has this magnified effect because it's a huge part of the state budget. So the total Medi-Cal budget, and this number kind of depends on who's counting what, but the total Medi-Cal budget in the state of California in 2016-17, which will be the coming budget year, is expected to be $87 billion. So as Lisa had pointed out, and it depends on whose numbers you use, but generally speaking, California spends less than the rest of the United States or other states' Medicaid programs. So for children, we're about 28th relative to other states. And for overall, for the total population, we rank 45th in terms of spending. So the state of California is a fairly miserly payer of service. They pay fairly low. I think where I saw recently was that overall average Medicaid spending is about 66% of Medicare spending. So if a provider was seeing a senior, a hospital was seeing an adult or an elderly person in the hospital, they would get that much more from Medicare. They'd get 66% of that if they were seeing that's for the same services at the Medicaid population. So Medicaid is not a very generous reimburser of services, and it's a huge problem for children's hospitals because Medi-Cal is the largest insurer of children. When we think of the Affordable Care Act, we think about, it expanded coverage for people, but it mostly expanded coverage, as I mentioned earlier, for adults. And if you look on the left-hand side of this chart, this circle on the left, it refers to Covered California, which is California's healthcare marketplace, and this is the public-private partnership that provides subsidized coverage for people who want to purchase insurance. So that marketplace covers 1.3 million people, most of whom are adults. So there's less than 80,000 children in Covered California. And you look at Medi-Cal, Medi-Cal covers nearly 6 million children, or over half of all California children. So the circle's a little confusing on the right because it's 43% of the total Medi-Cal population, so 43% of 13.3 million people are children or people under the age of 20, because that's the way they count them. But that amounts to almost 6 million children. So that's a huge payer, and it drives a lot of what providers think about in the state of California. So pediatric providers, by definition, are high Medi-Cal providers, which is a problem because Medi-Cal is, as I mentioned, a fairly miserly payer of service. So this chart here just reflects the 8 children's hospitals that are members of CCHA. So statewide, on average, hospitals have about 33% of inpatient days on average are Medi-Cal days. But for our hospitals, for pediatric providers, that ratio is like the lowest is Packard Hospital at Stanford, which is about 45%. And we have 3 hospitals on that chart, including CHLA, where the Medicaid percentage is over 70%. So 70% of all days are Medicaid days in those hospitals. So this is an issue because we have such a high volume of Medi-Cal, and we have not really, pediatric providers didn't really see a big expansion in coverage. So a lot of adult providers, some big hospitals in LA, for example, like county hospitals, they had a large number of uninsured patients. And so the justification always was, well, we have a large number of uninsured patients, therefore we need to get other sources of funding, and the federal government recognized that and reimbursed for that. And what's happened with the pediatric population is we never had a large number of uninsured children in California because we had relatively generous benefits. We cover a lot of kids. We cover kids up to about 266% of the federal poverty level under Medicaid in various circumstances. So the new enrollees that came into coverage under the Affordable Care Act were mostly childless adults. So there wasn't a big influx of coverage that occurred for pediatric providers. But at the same time, what we saw was a lot of policymakers saying, like, well, now we've got more people covered, so we really need to keep costs down. We really need to find a way to control costs. You don't have a lot of uninsured anymore, so some of the things that the federal government used to recognize and try to give providers a little bit of a bump, like there's a program called the Disproportionate Share Program for hospitals that had uninsured patients, those programs are going away and being cut back under the new federal rules. And what you have, so is sort of you're losing revenue on one side and you're not gaining more enrollees on the other side. The other thing is that there's been this big push for, under the Affordable Care Act, for delivery system reform. So there's this real drive. Everybody talks about kind of the triple aim, you know, improve patient experience, controlling costs better, and better population health outcomes. And those are all very good goals. But part of what's happening is it's increasing the pressure to kind of homogenize how we look at healthcare. And there isn't as much of an emphasis or a recognition that sometimes you have very special populations that need a different kind of approach. And so that's one of the things that we're kind of struggling with now. And I just want to give you quickly 2 kind of examples of how we see that sort of pushing its way through the system. The first is there's a small program in the state of California that's operated since 1927 called the California Children's Services Program. It covers about 180,000 kids who are very sick. These are kids with cystic fibrosis, leukemia, hemophilia. These are kids who need regionalized care because really you can't have a pediatric, you can't have like a cystic fibrosis center in every, or cystic fibrosis providers, pediatric pulmonologist specialists for kids with cystic fibrosis in every little town. It makes more sense to have that care regionalized, and that's the way it's grown up in the state of California. So we have this program that has special credentialing requirements for providers that see these very sick kids, and the state is saying now, because of the Affordable Care Act, they really want to move these kids into Medi-Cal managed care. So that's one of the things that we've been trying to deal with, is the state sort of sees Medi-Cal managed care as sort of a one-size-fits-all solution for everybody, because they see it as a way we need to get people into more organized delivery systems. But our question is, what are we giving up in exchange for that? Because we have this regionalized system that really promotes high-quality care for these really sick kids, you know, and how is that all going to turn out? So that's a debate that we're engaged in now with the state of California. But that's just one of the ways in which the state's really looking to try to use more organized delivery systems of care for this population of pediatric, for these kids. The second is that there's been this real big drive for improved provider accountability. And where we see this really coming into play is today, I saw on my way down here that the Integrated Healthcare Association was posting some information about a work group coming together to try to find better ways to get patients to not overuse healthcare, which is also a good goal. But one of the things we see is CalPERS, which is a big provider of health benefits to state employees, Medi-Cal, and Covered California all wanting to come together and have one single set of outcome measures, and they're pushing that down to providers. So we've seen recently information coming from the state where they want to hold hospitals accountable for reducing C-section rates. And they don't want health plans to contract with hospitals that have a C-section rate above 24%. And if a health plan does, then they have to justify why that's the case. So that's not necessarily a bad thing, but it's just that what you see is a consolidation of payers coming together around outcome metrics, and we better be sure that when we have these outcome metrics that they really work for the population that we're focused on. So there's this ongoing desire for more accountability, but there isn't going to be any more money associated with that. So we're sort of all being asked to do more with the same amount of money or less. So finally, I want to close by sort of talking about where this may be all be headed. And I don't think it's probably not rocket science when we think about this relative to where we've been and where the Affordable Care Act is going. But really, there's this intense effort to improve greater efficiency and accountability, and that's just going to continue. I mean, the population's growing, there's increased demands on these systems, and there's not more money, and there isn't going to probably be a lot more money. California's Medi-Cal program is going to probably remain substantially underfunded for the foreseeable future. It's just too big a program, and it's growing too fast, and there's really not going to be any great solution to how to come up with new revenue to continue to support expansion or increased funding. And that's only going to get harder for the state of California because the federal government's been paying for a larger share of the expansion under the Affordable Care Act, and that money is going to go away, so there's going to be an increased demand for state funds. And then, I think maintaining existing levels of federal support for California, just getting what we get now from the federal government is going to be increasingly hard in the future, and we've seen things coming out of Congress that suggest that there's going to be increased scrutiny. California is a big portion of the federal Medicaid spending, portion of the budget, and I think there'll be increased scrutiny around that too. So that's kind of the big picture. I think we're taking questions at the end, so I know I'm over my time already, so I'm gonna turn it over to Paul.